Sir, should I?
Yes, please.
Good afternoon, respected seniors and dear colleagues. We continue our series of talk under the cover of FOGSI ICOG Harmony web series on the endocrinology in women. And this is in association with Endocrinology Committee of FOGSI. This is our episode 4, where the expertise are giving a detailed talk to the PGs and even the working consultants to have the clarity onto the gynecology and the subject associated. Can I please request Dr. Chaitanya Ganpule to give us the welcome note and introduce our president and chairperson for the ICOG?
Good afternoon, everyone. Thank you, Dr. Madhu, for allowing me to speak for a couple of minutes. At the outset, I would like to thank FOGSI President Dr. Sunita Tandulwadkar and ICOG Chairperson Dr. Parag Biniwale for giving us an opportunity to be associated with ICOG for this FOGSI ICOG Hormony series on endocrinology in women. Now, we are in our 4th episode and we are having this episode every month, every third Wednesday of the month. We are conducting this web series for all the postgraduate students with specific topics, and we dwell with those topics in depth. And Dr. Vaishali Kordinayak is the co-convener along with me for this web series, and most of the things are done by her. And I would like to welcome the speakers for today, Dr. Anaga Gadikar, who is an associate professor and head of the unit at BJGMC and Sassoon General Hospitals, Pune, and Dr. Muralidhar Pai, who is the dean at Manipal campus in Assam. So welcome both of you, sir and madam. And I would now like Dr. Parag Biniwale, who is the chairperson for ICOG, to say a few words before handing it over to Dr. Madhu.
Yeah.
Over to you, sir.
Yeah. Thank you, Chaitanya. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all on the 4th episode of Hormony, which is a series conducted by the ICOG along with Endocrinology Committee of FOGSI. And let me appreciate the efforts put in by the chairperson of Endocrinology Committee, Dr. Chaitanya Ganpule, and Professor Vaishali Kode Nayak, who are the brains behind these program. Special thank you to our speakers today, Dr. Anaga Gadikar, who is one of the popular teachers from Pune, and of course, Dr. Muralidhar Pai, who is one of the best teachers of our times. Thank you, Dr. Muralidhar and Dr. Anaga, for sparing your time. And of course, we are lucky to have Dr. Sudha Prasad, veteran in the field of reproductive medicine. Thank you, Sudhaji, for joining today. And we await Dr. Kasturi Donimat, who's the ex-professor and HOD from KIMS Hubli. Today's episode, I'm sure it's going to be a great learning experience for all of us, because whenever we come across a case of amenorrhea, especially primary amenorrhea, then we at times are clueless as to what is to be done. But I think we could not have asked for a better speaker than Dr. Muralidhar Pai. Of course, Dr. Anaga will throw light on the basics of amenorrhea. So happy learning, everyone. And I hope we will continue to bring in such topics which are so relevant for us practitioners as well. Thank you very much.
Thank you once again. I would also like to extend my thanks to Dr. Sunita Tandulwadkar, President of FOGSI ICOG, Dr. Sheeta Mane Madam, who's Chairperson-elect, Professor Ashok Kumar, and Dr. Suvarna Madam. We continue our series by introducing our Chairperson, Dr. Sudha Madam. Can I please have the CV of Dr. Sudha? Vaishali ma'am, can you introduce Dr. Sudha ma'am?
Sure, Madhu. Thank you. So, Professor Sudha Prasad Madam is MD and FICOG, FICMCH. Madam is Director Matritwa Advanced IVF Maternity Center, Palamgar, Gurugram. And she has teaching experience of more than 40 years. Madam is a former professor and IVF coordinator, IVF and Reproductive Biology Center at Maulana Azad Medical College, Delhi. And she has worked at very respected positions, and she had a fellowship from Texas. So Madam is the apt person for today's session as chairperson. On behalf of ICOG and FOGSI Endocrine Committee, we welcome you, Madam.
Thank you. Thank you so much, dear.
Our second chairperson, Madhu.
Yes, ma'am.
Madam
Ma'am, Dr.
has-
Kasturi Donimat, ma'am. She is also joined.
Yes.
Yeah.
So we welcome Madam. Madam is immediate past president of KSOGA, and she is professor and head at Kims Hubli Department of OBGY. And Madam has also been principal investigator in many research projects. She is UGPG examiner, MCI inspector, and many accolades at her credit. We welcome you, Madam.
Yeah, thank you so much. Yeah, thank you.
Thank you so much. Yes, Madhu.
Yeah. Ma'am, we
We'll
have
go
our
ahead
first
with first speaker.
we have our first speaker as Dr. Anaga Gadikar, who's going to talk about an overview about amenorrhea. Can you as well, ma'am, just introduce her in brief? Dr. Anaga?
Yes. Dr. Anaga Gadikar Madam or Jinturkar Madam is a very well-known teacher from Pune, associate professor and unit head at BJ Medical College, and a good friend of us. And we welcome her for this session today, and she's going to give us an overview about this amenorrhea. So we welcome you, Anaga. Please unmute yourself, and we are eagerly waiting for your talk.
Good afternoon, everybody. Am I audible?
Yes,
Yes,
you are.
ma'am.
At the outset, I will thank Dr. Chaitanya Ganfule, Dr. Parag Biniwale sir, and Dr. Vaishali Kode Naik madam for inviting me to deliver such a important topic in a hormonal era of gynecology, which is amenorrhea. So, just I will begin with my topic. Amenorrhea by itself is says it is absence of menses. The age, as we all know, age at which the menarche should express varies from different person to person, depends on different age of onset of puberty. In general, first menstrual cycle should appear within 2 to 3 years of the pubertal development. The first sign of puberty is an acceleration of the growth, which is called as a growth spurt, which is followed by breast budding, which is thelarche, and appearance of pubic hair, that is adrenarche, and finally menarche occurs. So in general, what is under these headings, I will be proceeding with my talk, that is basics of menstrual cycle, which might have been taken in the previous lectures, basic requirements for having a normal menstrual cycle, causes of amenorrhea, what are the types of amenorrhea, whom to evaluate, and how to go ahead with evaluation of amenorrhea, and finally the management of amenorrhea. Basic menstrual cycle. As we know, basic requirement for normal menstrual cycle does include 4 anatomically and functionally distinct structural components. So it is a complex thing, as we all know. We need to have a patent genital outflow tract, including uterus, cervix, and vagina. Ovary should be functional, the pituitary gland and a hypothalamus, all these in coordination should work together to have a normal menstrual cycle. It does provide a natural and useful hierarchy for organizing a diagnostic evaluation of amenorrhea. So all the components, that is right from the CNS system to the endocrine system, everything should function in coordination to have a normal menstrual cycle. So all these things, as we all know, the environment also plays a very important role. Then comes to the central nervous system. Then comes hypothalamus, which has a pulsatility in secretions of GnRH, that is gonadotropin releasing hormones, which work on anterior pituitary to release follicle stimulating hormone and LH luteinizing hormone on ovary. So it works on ovary to secrete estrogen and progesterone, which comes in cyclical way. This LH surge is responsible for ovulation and changes in the internal lining of the uterus, that is endometrium, and which results into an observable finding, which is menstruation. So what is the role of hypothalamus? Hypothalamus is supposed to be a pulse generator. It is the main key factor in inducing the changes of puberty and resulting into the final goal, that is menstruation. So the arcuate nucleus of the hypothalamus secretes gonadotropin releasing hormone, that is GnRH, in pulsatile fashion. These GnRH pulses are essential for stimulating pituitary gonadotropins. The high frequency pulses, the more number of high frequency pulses, the more is the LH secretion, and low frequency pulses, more is the FSH secretion. So this information is very essential for us to know about the further problems of infertility, like that is anovulatory infertilities. This pulsatility begins in the late childhood, that is gonadarchy, and inhibitory effects of central neurotransmitters like GABA decrease, and excitatory inputs like kisspeptin and glutamate will increase when the lady approaches pubertal changes. While the second factor, second organ which is responsible is pituitary, which is also called as an amplifier. So it amplifies the effects of hypothalamic hormones. The anterior pituitary, as per se, gonadotropins, they respond to GnRH pulses and they secrete two hormones, which are follicle stimulating hormones, which release or stimulate the follicular growth and estrogen production in the ovaries, and luteinizing hormones, which triggers ovulation and luteinization, which is an after effect of ovulation. Pituitary secretions are modulated ineffectively by positive feedback by high estrogen in the mid-cycle level and negative feedback from estrogen and progesterone in the luteal phase. So inhibin from the granulosa cells selectively inhibits FSH. This mechanism is responsible for having anovulatory cycles in some cases and resulting into amenorrhea. So pituitary factors can be evaluated by knowing this knowledge. Ovary, it is the final effector organ responsible for pubertal changes and also ovulatory changes. The folliculogenesis is recruitment of primordial follicles by selection of dominant follicle under FSH stimulation. The estrogen production occurs and there is a two-cell, two-gonadotropin model. That is, theca cells are stimulated by LH to produce androgens, and granulosa cells are stimulated by FSH and they aromatize androgens into estrogens. So when there is an imbalance between LH and FSH secretion, there will be a possible outcome of anovulation and leading to amenorrhea, as in cases of PCOS, which we are seeing nowadays very frequently. Ovulation occurs when the LH surge causes follicles to rupture. So higher estrogens lead to follicular growth and LH surge comes in and the follicle ruptures. Post-ovulation, the corpus luteum produces progesterone. So if there is no pregnancy, the corpus luteum regresses and there is drop in the estrogen and progesterone levels leading to menstruation. So all these things should work in coordinates to cause ovulation and post-ovulatory changes in the endometrium. While uterus and the outflow tract should also be patterned to respond to all these changes. The endometrium responds to the estrogen, as in it is a proliferative phase of endometrial cycle, and progesterone has a secretory phase. While when the proliferative endometrium is acted upon by progesterone, it leads to a secretory phase, and this is a functional endometrium which is shed during as a menstrual blood via vagina. When the outflow tract is patent, then there is menstrual blood which exits via vagina. So in short, what can be the causes of amenorrhea? Therefore, many causes of amenorrhea can be distributed according to the site or the level of disturbance. So this disturbance can be at the level of genital outflow tract and uterus. It can be disorder of the ovary. It can be disorder of anterior pituitary and disorders of hypothalamus and central nervous system. So all these systems should be evaluated when we are evaluating a primary or secondary amenorrhea case. So amenorrhea can result from congenital or acquired disease or a dysfunction at any level in the system and can involve more than one mechanism. So for any amenorrhea, you have to evaluate the patient for one or more causes which can coexist together. So causes of amenorrhea: congenital genital abnormalities. The abnormalities can be complete vaginal or uterine aplasia, that is Mullerian agenesis. It can be a transverse vaginal septum. It can be pseudohermaphroditism. It can be imperforate hymen. Cervical stenosis is quite rare. While acquired uterine anomalies which can lead to amenorrhea are Asherman syndrome. It can be endometrial tuberculosis, obstructive fibroids, polyps, or any history of previous surgery on the uterus which has destructed the functional layer of endometrium. So anatomically, we can have these many arrays of etiologies for amenorrhea. In hypothalamus, it can be a stress, which can be physical or emotional, eating disorders, excessive exercises, obesities, excessive weight gain or weight loss, chronic systemic diseases, idiopathic primary ovarian insufficiencies, or CNS tumors can lead to amenorrhea. While in pituitary, there are thyroid diseases which can be hypo or hyperthyroidism, pituitary adenomas, hyperprolactinemias which can be drug-induced, physiological, idiopathic. It can be craniopharyngiomas. Other pituitary tumors can lead to amenorrhea. And hypopituitarism, empty sella syndrome, or pituitary infarcts, which can lead to Sheehan syndrome, as we see post-delivery. In ovaries, it can be a polycystic ovarian disease syndrome or premature ovarian insufficiency or any ovarian neoplasm which has destructed the functional ovarian tissue. In uterus, the primary cause of amenorrhea, you have to rule out pregnancy in any case. Endometrial atrophy, which can be drug-induced or without any uterine interventions. In cervix, it can be cervical stenosis or cervical obstructions, which can be seen by any obstructive pathology at the level of cervix. In adrenal tumors like Cushing syndrome, adrenal adenomas can lead to congenital adrenal hyperplasia, and which presents as a case of amenorrhea. In systemic, the chronic systemic illnesses, most commonly it is tuberculosis, can lead to amenorrhea. And exogenous drug intake history has to be asked to the patient in the form of injectable contraceptions, which leads to thinning of endometrium and leads to amenorrhea, which is usually a secondary amenorrhea. What are the, in short, what are the types of amenorrhea? A primary amenorrhea and secondary amenorrhea. As whom to evaluate is a question. So patient fulfilling any of the criteria should be evaluated for amenorrhea. First of all, there are no menses by the age of 14 in the absence of growth or development of secondary sexual characters. No menses by the age of 16, regardless of presence of normal growth and development of secondary sex characters, or in women who has menstruated previously, but no menses for an interval of time which is equivalent to total of at least 3 previous cycles, or no menses over a period of 6 months. So in short, how to evaluate amenorrhea? Hypothalamic causes can be evaluated by giving them a basic test, which are thyroid stimulating hormone, serum prolactin, serum estradiol, serum FSH, progesterone challenge, and endometrial thickness evaluation by ultrasonography. If there is high or low TSH, let us evaluate this patient for thyroid disorder, which can be a cause of amenorrhea. Hyperprolactinemia can be there with and which can be corrected with anti-dopaminergic drugs. Then the next case is normal estrogen production. If there is a normal estrogen production, then there is a possibility of chronic anovulation, which leads to amenorrhea. When there is a low estrogen production with a high FSH, suspect ovarian failure in these cases, which can be evaluated in further by karyotyping that patient or any ovarian dysgenesis. Normal or low FSH can be evaluated with the help of MRI for ruling out pituitary adenoma and hypothalamic amenorrhea. These pituitary adenomas are further evaluated by testing certain hormones, which are lactotropes, that is prolactin. If the prolactin level is more than 100, it is macroadenoma, and it is responsive for a simple surgery like pituitary adenoma removal. While microadenomas can be treated with drugs which are usually used for which presents as galactorrhea, and which are bromocriptine-like drugs and cabergoline type of drugs. While thyrotropes are, if pituitary adenoma is secreting thyrotropes, then there is a role of surgery because it directly affects the thyroid hormone levels. Then it comes as adenomas which are removed by seen with MRI and removed with surgeries. Evaluation of primary amenorrhea. If there are no menses in a patient with no breast development, no menses by the age of 15 with a breast development seen, then you have to take detailed history of the patient, about a detailed history about her birth history, her physical examination, her clinical examination, her pelvic scans are to be done, serum beta HCG levels are to be done to rule out pregnancy, FSH, TSH and prolactin levels are to be assessed. If she is pregnant, then the cause of amenorrhea is obviously ruled out. If the uterus is present and uterus is absent, if the uterus is absent, then the patient undergoes karyotyping. If she is 46XX, it is Mullerian agenesis. If she is 46XY, there is complete androgen insensitivity syndrome. It is phenotypically female, but normal range of male testosterone are there in her, so that she is not having menses. Then it can be an 5-alpha reductase deficiency, in which there is inability to convert testosterone into dihydrotestosterone, and it leads to amenorrhea. When the uterus is present with a low FSH and LH, it is a case of hypogonadotropic hypogonadism. If there is normal FSH and LH, then evaluate the patient according to breast examination. If the breast examination reveals a normal study, then repeat the investigations, and it can be a constitutional delay of puberty or congenital GnRH deficiency or other HPO axis deficiencies. If anatomically breast development is abnormal, then you have to check for high prolactin and TSH hormone. High FSH can lead to primary ovarian insufficiency, and you should rule out a Turner's or presence of Y chromosome in her. Primary amenorrhea can be managed with uterus. When the uterus is absent and it is Mullerian agenesis, vaginal reconstruction and surrogacy for the baby is the treatment. If it is 46XY, then it is gonadal reconstruction with gonadectomy is the treatment. While if it is 5-alpha reductase deficiency, it is also treated with gonadectomy along with vaginal reconstructions. If the uterus is present and there is outflow tract obstruction because of imperforate hymen or transverse vaginal septum, the treatment primarily is surgical treatment for hymenectomy and septal resection. If there are no anatomical abnormalities identified with high prolactin and TSH, then the treatment of pituitary adenoma is mandatory for her case. When the patient has high FSH and primary ovarian insufficiency, she is a case of Turner syndrome or presence of Y chromosome. So she undergoes a treatment of HRT with oocyte donation for getting pregnant. So HRT is the treatment for such patients. Evaluation of secondary amenorrhea. In short, you do beta HCG or UPT. If she is a pregnant patient, you have to rule out ectopic pregnancy in her case. If there is negative urine pregnancy test, check for TSH and prolactin levels and investigate further. If they both are normal, the TSH and prolactin are normal, give her progesterone challenge test. If there is a withdrawal bleeding, it is normogonadotropic hypogonadism. It can be a case of hyperandrogenic anovulation, PCOS, or Cushing syndrome. If there is no withdrawal bleeding, estrogen and progesterone challenge test is done. Even if after estrogen and progesterone challenge test, there is no withdrawal bleeding, then you have to rule out outflow tract obstruction, or it can be an inherent deficiency in the formation of endometrium in cases of Asherman syndrome. Withdrawal bleeding is present, then check for FSH. If FSH is more than 20, it is hypergonadotropic hypergonadism, which is a etiology of premature ovarian failure. If FSH is low, do MRI to evaluate pituitary tumor, and normal MRI. When there is a normal MRI, it is hypogonadotropic hypogonadism. And otherwise, if there is a tumor, then you have to rule out that tumor for its treatment. If the prolactin level is more than 100, do MRI to evaluate for hyperprolactinemia. And if it is negative, consider other causes like medications. Certain medications lead to hyperprolactinemia. So you have to ask the patient history about consumption of those drugs.
Anaga, our 10 minutes are over the time. So can we request you to wrap up? Because Muralidhar sir is there. So we will follow that.
Yeah. So I have covered this also. So
so we are going to have detailed primary and secondary also. Yeah. So. Okay. So Madam has given us a great overview and it's a very complex topic. It's actually, we are covering it in next 2 sessions. Today's one session we have dedicated only for primary amenorrhea because there are so many factors, there are so many reasons, every evaluation and treatment. We have multiple things to cover, but I congratulate Dr. Anaga. She gave us a good overview, and now I think it's time for Muralidhar Pai sir to give us a complete overview about primary amenorrhea. Thank you, Anaga. Please, can we have sir's slide? Yes. For this talk, when we planned this particular web series and we were thinking of endocrine problems, and when we came to primary amenorrhea, we wanted a person who will make it simple as well as it will help to students as well as to clinicians. And we unanimously thought of Professor Dr. Muralidhar Pai sir. And there is very less we can talk about such a big personality. Sir is right now Pro-VC of Sikkim Manipal University and Dean at Sikkim Manipal Institute of Medical Sciences. He's professor of ONG, obviously. And to his credit, we all can see like 37 years of academics, 30 awards, 15 international fellowships, 208 publications, 3 textbooks, and so many, around 1,000 guest lectures. So, sir, we are all ears to you, and my chairpersons will also agree. We want to learn from you how to teach this topic of primary amenorrhea. So, sir, that
everybody knows Muralidhar is a big
ma'am.
academic person, and I think the students will be benefited.
Yes, and today
Thank you, Doctor.
I'm very happy for the students that they are going to learn all over the nation, and this is being recorded. It will go on ICOG website. So anytime they have this, they can refer to this lecture to understand such a complex topic.
Very rightly said. Thank you.
Yeah, thank you very much, Dr. Vaishali and Dr. Sudha, madam, for your kind words. And I thank Dr. Parag for inviting me to give this lecture. And I must compliment Dr. Anaga for beautifully elaborating the basics of the endocrinology, the pituitary, ovarian, hypothalamo-pituitary axis, and other things, and also her excellent, exhaustive, insights into both primary as well as secondary amenorrhea. Yes, I agree with Dr. Vaishali that it's definitely a complex topic, but it's my favorite topic. I made sure that it became my favorite topic because I was finding it very difficult when I was a PG. So I said I must master this, and I must also teach my students so that they will never forget it throughout their life. So I will try to make it as simple as possible. And I'm sure after this talk, everybody will have primary amenorrhea on their tips, and they will never, ever, ever get confused. There were some very big algorithms. I have broken down them into very, very small algorithms so that everybody can understand this very simply. So what I normally tell before I start my talk, I tell my students that, you need to have two systems working hand in glove. Otherwise, there won't be normal menstrual cycle. What are these two systems? Number one, I call it central government and state government. Both central government and state government should be hand in glove. Only then can the subjects be very happy, right? So central government here, I call HPO axis. All of us know that. Hypothalamo, pituitary, ovarian axis. Though it is central government and ovaries in the pelvis, I consider it is as an ambassador of the central government. The ovary is situated in pelvis, but it belongs to central government. Now, what is the state government? State government is the apparatus, that is uterus, intact uterus, intact cervix, and intact vagina. Now, these two systems should work hand in glove. If there is any problem in either of the systems or both systems, there will be problem. The problem can be amenorrhea and other menstrual disorders. Today, we are concentrating on amenorrhea. In that, we are concentrating on primary amenorrhea. So this is one basic thing I teach my PGs. The second basic thing that I teach is that whenever you say primary, right, that is right from the beginning. Whenever you say secondary, it started somewhere later in life. Now, when something is right from the beginning, you have to think of drastic things. As drastic as there is no uterus. That's very drastic, isn't it? There is no ovary. You can't say there is no pituitary, but let's say there is something grossly wrong with pituitary or something grossly wrong with even the hypothalamic systems. So these gross things can give rise to primary amenorrhea. Whereas in secondary amenorrhea, it won't be that gross because the lady has menstruated sometime in her life. So HPO axis has functioned. There's nothing grossly wrong with it. Uterus, cervix, and vagina were intact because they have menstruated. There is nothing grossly wrong with them. But down the line, something went wrong with them. So I hope if you have this basic idea that, number one, you must have a intact hypothalamo-pituitary ovarian axis and the uterus, cervix, vaginal axis. Number two, there should not be any gross abnormality in either of these systems. If there is, then there will be primary amenorrhea. Once you understand this, rest of the things become very easy. We are playing with only 6 things: hypothalamus, pituitary, ovary, uterus, cervix, vagina. That's it. Nothing else. Okay. Now let's go on. The definition. Dr. Anaga has already told this definition. I'm simplifying it. There were so many lines in that slide, but just remember one thing. 16 baras ki umar, bali umar, that's the thing. Sweet 16. All of us know this, right? So simply remember, by definition, failure of onset of menstruation beyond the age of 16 is primary amenorrhea. This is enough to remember. One number, sweet 16. But then if you want to make the definition better, you can add other clauses like regardless of development of secondary sexual characters. Dr. Anaga told us correctly that Initially, there will be a growth spurt, then there will be thelarchy, then there will be pubarchy, and finally ends in menarche. Now, when you say primary amenorrhea 16 as one cutoff, it is regardless of development of secondary sexual characteristics. She may have developed a few or all of the secondary sexual characteristics. She may have had the growth spurts, everything, but the maximum we can wait is 16 years. We can't wait beyond 16 years. That's the meaning of this particular definition. But when it comes to practicality, when to start the workup? Do we blindly wait till 16 years? Do we, send back the patient and the patient party home, come after 16 years? No. There is a slight difference there. Suppose by the age of 14, menses has not occurred and the onset of puberty signs such as breast development is absent, right? A workup for primary amenorrhea should start because thelarchy is the first one to happen and that itself has not happened, and you have waited till 14 years because all these developments occur very early. Now we have seen girls menstruating by the age of 11, 12 itself. So in spite of the breast development and she has attained 14 years, there is no menses, you don't have to tell the patient come after 2 more years because there is already some breast development. There is some endocrine hormones that are there, isn't it? So you can start the workup at 14 years itself, right? In the presence of secondary sexual characteristics, okay, if the breast has developed a little bit, then you can comfortably say, since there is a development of breast, there is some activity, you can wait for 2 more years. I think I told earlier a little bit wrongly. By the age of 14, if there is no breast development at all, then we have to start the workup early. Whereas if there is breast development, there is some hope, so we can wait up to 16. I hope I am clear. If there is no secondary sexual characteristics, you can start the workup at 14. If there is evidence of secondary sexual characteristics, you can wait up to 16. Though the definition is by 16, she should attain menarche. So after clarifying definitions, let us go for the detailed evaluation. Dr. Anaga has given you the battery of investigations, but I would suggest the first investigation, whether it is with a case of primary amenorrhea or we are dealing with a premature menopause, whatever it is, the first hormone to be done is, the FSH. But before that, we go for a history, detailed history. Since it's a case of primary amenorrhea, it is better to get her growth charts, whether there's been an optimum growth during her childhood. We can get this easily from the pediatrician. If there is a stunted growth, that will tell so many things. Height and weight records. This is very important because we know that obesity and other things will affect her hormones. Chronology of development of secondary sexual characters. This is a very famous MCQ question. We all have solved that. Thelarchy, adrenarchy, and menarche. Okay, so this is the order. First is breast development, then the pubic hair and other secondary sexual hair, and then comes the menarche. Body habitus, whether she has webbed neck, whether she has got big carrying angle, whether there are any humps, whether there's any obesity. So these body habitus has also to be evaluated. What about cyclical abdominal pain? Suppose she has not menstruated, but every month she has got, this would suggest cryptomenorrhea. That means she must be menstruating inside, it's not coming outside, and that's a typical case where there could be imperforate hymen or transverse vaginal septum or cervical atresia, right? So cyclical abdominal pain is another important history that we must have. Then, of course, they're very, very rare for a girl before there is menses to have tuberculosis of the genital tuberculosis. Extremely rare, but you cannot totally rule it out. Also, history of thyroid disease. Usually, thyroid disease will cause secondary amenorrhea, but one odd case can be there. Juvenile diabetes. right? And then mumps. Mumps is one thing which can be destroying the both ovaries as well as testes very early in life. So history of mumps and juvenile diabetes is also important. The physical examination goes the next. I'm taking it like a clinical case because sometimes if you have a case of primary amenorrhea, postgraduate will definitely get a case. And this is a case where you can actually score 100 out of 100 if you know perfectly. Examination stature. I already explained short stature, web neck, and the high carrying angle is a typical case. It is written on her that she is a case of Turner's. So similarly, tall girl, there will be Kallmann syndrome, right? Height and weight ratio. This is again a very important thing in every case of primary as well as secondary amenorrhea. Annual evaluation of maturation status of secondary sexual characters, both breast and pubic hair. Today, I'm not going to elaborate on that, but all of you know about Tanner classification, how much of breast development and pubic hair development has occurred. Genetic and endocrine stigmata, which I've already explained. And then presence of vagina and uterus by ultrasound. Of course, a small examination with her permission is allowed to see whether there is imperforate hymen or if there's a vaginal just dimple. This can be done, but we don't do generally per vaginal examination in girls who have not yet menstruated. But nowadays we have such wonderful ultrasound, high resolution ultrasound. We can always do a abdominal ultrasound and find out whether there is uterus, whether there is ovary, whether there is a small short vagina. All these things can be easily made out by ultrasound. If you have any doubt, of course, you can always go for MRI. Now I come to the investigation, which I prematurely revealed the secret 2 slides before. My favorite marker is FSH. Whether she's a case of amenorrhea, primary, secondary, or whether she is a case of doubtful menopause, or that is premature ovarian insufficiency, the first and the foremost hormone to be assessed is FSH. There is a reason for that also, because the classification of primary amenorrhea is based on FSH. I'll come back to this again. The next one, of course, is estradiol. After all, FSH cannot act on its own. It has to act through estradiol. It will act on the follicles of the ovary, and follicles will secrete estradiol, and all the secondary actions or all the secondary characteristics that you see are because of estradiol, whether it is breast development, whether it is development of the uterus, whether it is development of vagina, whether it is development of endometrium, all that are dependent on the estradiol. So the next investigation to be done is estradiol, because after all, as Anaga said, in secondary amenorrhea, only estradiol primed endometrium will respond to what is called progesterone challenge test. That means you give progesterone and withdraw the progesterone. She will menstruate only if that endometrium was primed by estradiol, otherwise no. Then comes, of course, prolactin. We all know prolactin, thyroid stimulating hormone. These are all close cousins of FSH, LH, all these people. So hyperprolactinemia is a very well-known cause of primary amenorrhea, which could be either just a idiopathic or just could be due to a microadenoma or macroadenomas in the pituitary. Right. The next one is radiological evaluation of the bone age. Sometimes you may be confused about the age of the patient, especially if she didn't know the date of birth. That never happens these days, so we don't have to do this. X-ray skull MRI to rule out pituitary macroadenoma, which goes without saying. That's the best way to diagnose if the prolactin is very high, more than 100. So you can go for a X-ray skull, empty cellular syndrome, what we say, or MRI also can be done. Karyotyping. Yes, this is very, very important. I mentioned about one syndrome already, that is Turner syndrome. You can only suspect by physical examination, but you have to confirm that by karyotyping. So, and when do you do karyotyping? Do you do it for everybody? No, you do it only when the FSH is more than 40. What does it mean? Pituitary is trying its level best to beat the ovary to produce estradiol, and ovary is not doing the same. That means there is something wrong with the ovary. So how do you confirm that? Only by doing karyotyping. Of course, we don't have to take biopsy. The nowadays don't do that at all. Even testicular biopsy is not done. TSH, testosterone, RFT in select patients. As I already told you, TSH is a close cousin of FSH, and hypothyroidism, also hyperthyroidism, can give rise to amenorrhea. Testosterone, of course, very high testosterone will give rise to amenorrhea. Usually it is seen as PCOS, which is typically secondary amenorrhea, but one odd case can be primary amenorrhea. RFT, because 30% of the uterine anomalies or the reproductive organ anomalies are associated with renal anomalies. So it's an indirect way of finding out there could be a uterine anomaly. If there's grossly something wrong with RFT, you may suspect there is some renal anomaly, and that's why there could be uterine anomaly as well. Yes, I have reiterated or highlighted FSH again, made it red. FSH is the most single important hormone to be evaluated. If somebody asks you, some examiners have the habit of asking this kind of questions. What is the single, if I allow you to do only one hormone study, and what that would be? And the answer is FSH. Now, as I told you, the reason for that is not only evaluating FSH and to see the actual classification of primary amenorrhea is based on the FSH levels. There are several ways of classifying primary amenorrhea, but let me start with this because this is the most important, and this will explain most of the causes of primary amenorrhea. So this is the classification. What is that? Hypergonadotropic hypogonadism. Here, obviously, FSH is more than 40. Estradiol is less than 40. To be precise, less than 25 picograms. But if you simply remember it as FSH more than 40, estradiol less than 40, both can be okay. Hypergonadotropic hypogonadism. That means pituitary is the master of the ovary, right? So it is trying its level best. It is giving the maximum FSH to make sure that the ovary produces some estradiol, but ovaries are not producing estradiol. It is less than 40, or to be precise, less than 25. What are the reasons? Number one, it could be due to abnormal sex chromosomes. That's what we have to think. I told you, remember, we have to think drastically wrong. She may not be female at all. To that extent, you can think, right? Drastically wrong. So abnormal sex chromosome. What is this abnormal sex chromosome? Gonadal dysgenesis and the famous 45XO, Turner syndrome. This is the usual cause of hypergonadotrophism. There could be mosaicism, or sometimes there could be abnormal X. Even though there is 46XX, one of the X could be abnormal X. But whatever it is, Turner syndrome is the most common cause of primary amenorrhea. B, normal sex chromosomes. Now, abnormal chromosomes, easily understandable that ovaries may be at fault. Whereas when there is normal sex chromosome, it is slightly difficult to understand, but doesn't matter. There are only 3 problems there. Number one, 46XX, the sex chromosomes are normal. 15% of the time, it's called pure gonadal dysgenesis. That means the gonads are 24 karat gold, but there is dysgenesis. There's no proper development. There's no proper secretion of the estradiol. Very difficult to explain this, very difficult to understand this, but we have to just remember it is called pure gonadal dysgenesis. The next one is 46XX, normal, female. 46XY we can understand, but you may ask me, how can it be female if there is 46XY? I have to go into another big lecture, but I will not do that. I will simply borrow one slide from that big lecture. The big lecture is on differentiation of sexual organs. There, if you see, SRY gene is the most important gene in the Y chromosome that will determine whether the baby is going to be male or female. If SRY gene is present in the Y chromosome, it will be a typical male. But what happens if there is XY, all right, which is a male endowment, but that Y chromosome does not have dark blue line. That is called SRY gene. It is absent here. When it is absent, the endowment is XY. For all practical purposes, it will be like a female. That's what. As I told you, I hope you understood this. The SRY gene is deficient in the Y chromosome of this particular child. That's why even though the child was supposed to be male, it will be like a female, and this will be called XY Swyer syndrome. Whereas there are XX Swyer syndrome also, which is extremely difficult to again understand, but we should know that if there is Swyer syndrome, there will be problem of secretion of estrogen. And finally, gonadotropin resistant syndrome. See, having XX and having these receptors is not enough. If these receptors are not accepting FSH to sit on them, then they can't produce estrogen anymore. And this is called savage syndrome. Savage in the sense in ancient times, like animals. Animals, they get estrus once in a way. Every month they don't menstruate, isn't it? So because their chromosomes or their things are not, receptors are not accepting the FSH. So there are only 4 things that we have to remember. If there is abnormal sex chromosome, Turner syndrome. If there is normal sex chromosome, pure gonadal dysgenesis, Swyer syndrome with XX or XY, and then Savage syndrome. So this is what we have to remember. The next one is eugonadotrophic. Now this is the most difficult part. Hypergonadotrophic you can understand easily. That is something wrong with the ovary. That's why pituitary is hyper. Now pituitary is U. That means normal. There's normal secretion of FSH. Here you get confused. Let us see what are the problems. If the FSH is normal, that means ovary is normal. Now, whom will you point the finger? It's normal common sense. I told you, remember, initially itself two systems. If one is HPO system, other one is uterus, cervix, and vaginal system. Now, if eugonadotrophism is there, HPO system is all right. Now, where will you look for? You will look for the problem in the other system. So, typically, there will be absence of the uterus. And I also told you that my second general formula is that you have to think drastically wrong, right? What is drastically wrong? Absence of Mullerian development. That's drastic as that. So androgen insensitivity syndrome, wherein it is called also testicular feminization syndrome. There's no development at all except the development of the breast. Androgen insensitivity. The second one is absence of the uterus and vagina itself, which is famously called RKH syndrome, Rokitansky-Koster-Hauser syndrome. So Mullerian agenesis, because FSH is normal. FSH is normal because the ovary is responding. That's why I will not find fault with HPO system. I have to find fault with the uterus, cervix, and vagina. So first one is Mullerian absence of the Mullerian development. This could be due to 2 things. One is androgen insensitivity. Other one is Mullerian agenesis due to RK syndrome. Suppose there is normal Mullerian development. That means uterus is there on ultrasound and X-ray. So where will you place the lesion? It could be a case of female or true intersex, which is extremely rare, or typically it is PCOS. In PCOS, sometimes you can have eugonadotrophism, even though typically we say LH is high, FSH can be low and it could be normal also. Whereas the problem is something wrong with their coordination because uterus is there. Other one is adrenal or thyroid disease. The cousins are playing game. Which are the cousins? Adrenal and thyroid disease. Or it could be septomenorrhea. As I told you, she is menstruating, but it is not coming out. Why it is not coming out? It could be due to imperforate hymen. Again, here we are giving clean chit to HPO axis. We are finding fault with the other system. Uterus is one thing. Vagina is another thing. Imperforate hymen. Vaginal septum. All of us know that vagina comes from two places. One is vaginal sinovaginal bulb and one is from the Mullerian system. If there's no breakage between these two, there will be vaginal septum. Then, of course, we totally go out of these two systems, that is tuberculous endometritis. I told you it's extremely rare as a cause of primary amenorrhea. It is typically a cause of secondary amenorrhea, but still we have to consider that. So hypergonadotrophism is over, eugonadotrophism over. Now let's go to hypogonadotrophism. Now when you say hypo, one clue I can give you, hypo means hypothalamus, isn't it? So the problem is with the hypothalamus and pituitary. The problem is up somewhere there. FSH is very low. Why FSH is low? Usually pituitary produces the FSH, but it takes instructions from the hypothalamus. So hypothalamus is not giving instructions. So hypothalamic causes, as already Anaga has told, it is influenced by all external things. There could be constitutional also, like delayed menarche or delayed puberty. You can ask history whether mother had delayed menarche, whether her sister had delayed menarche. If there is no, then you have to look for other things like hypothalamic hypogonadism due to Kallmann syndrome. This is another syndrome that we have to keep in mind. Psychogenic causes, extreme weight losses or extreme weight gains, stress, as simple as that she has changed the school, she has changed the hostel. This also can be a cause of amenorrhea. Anorexia nervosa or malnutrition and taking some psychotropic drugs. Then we come to pituitary. We have to think of pituitary problems also. Typically underdevelopment, which is seen by short stature, obesity, genital dystrophy or mental retardation, polydactyly and rhinitis pigmentosa. Other causes of pituitary hypogonadotrophism is neoplasms. This has already been understood. Prolactinomas, craniopharyngiomas, adenomas, and empty sella vesica. Pituitary states like Simmons disease, Chiari-Frommel syndrome, Forbes-Albrecht syndrome, and pineal gland tumors. Severe systemic disease sometimes can cause hypogonadotrophic problems like tuberculosis of the, here it is not the genital tuberculosis, we are thinking of the central nervous system here, tuberculosis, syphilis, but it is extremely rare to find. Other endocrine disorders like thyroid and adrenal, which are outside the typical reproductive system, but they are cousins of FSH. Now we have understood one classification and very slowly and nicely. Now there should not be any problem to understand quickly etiology according to the location. Whichever way you are shaken in the exam, you should be able to answer. What I mean by this is delayed puberty. Where do you place the lesion? Hypothalamus, constitutional, isn't it? We start from above. Then pregnancy before menarche, extremely rare, but again, this is something to do with ovulation and there was a rape or something like that, but we don't usually think of this. Then we come to cerebral cortex. We are coming from above, right? Stress, emotional disturbances, infection, trauma, tumor. I don't have to explain again. It has been already explained. After cerebral cortex, what do you think? Hypothalamus. Hypothalamus is influenced by cerebral cortex. Now, as far as hypothalamus is concerned, Kallmann syndrome, vigorous exercise, weight loss. Then comes pituitary, empty sella turcica, Cushing's syndrome, pineal tumors, prolactinoma, Frawley syndrome. I'm just putting the wine in different glasses or different bottles. Same wine, same theme. After pituitary, any guesses what organ comes next? Obviously, ovary. In ovary, I told you only 4 things. Turner syndrome, pure gonadal dysgenesis, Savage syndrome, and of course, PCOS and 17-hydroxylase deficiency also you have to think. Genital tract comes next, absent uterus, refractory endometrium, maybe due to tuberculosis, obstruction to the lower tract, maybe vaginal septum, or maybe the imperforate hymen. Chromosomal, we can go deeper down, intersex, Turner's, and testicular feminization syndrome. Endocrine, juvenile diabetes, thyroid and adrenals. We have already asked the history of these things. And drugs, I psychotropic drugs can also cause amenorrhea, typically secondary amenorrhea, but sometimes it can be primary also. Tranquilizers, antidepressants, and antibiotics. So this is a second way of seeing. One is based on FSH, hypergonadotropic, eugonadotropic, and hypogonadotropic. Second one is depending upon the location, hypothalamus, pituitary, ovary, uterus, vagina, and things like that. Now, of course, nutrition, overweight, weight loss, and malnutrition. Now, clinically, my professors used to always teach me this. That is theory. Based on FSH is pure theory, based on location is pure theory. In a given case, how do you clinically characterize? It is based on the secondary sexual characteristics. Again, there are three divisions. Number one is normal secondary sexual characteristics. Typical female, we can say. What are that? Suppose normal secondary sexual characteristics are present, we are giving clean chit to hypothalamus, pituitary, and ovary. Yes or no? Yes, we are giving clean chit. Then I have to look. You can look from below. It could be imperforate hymen, if hymen is not intact. It could be transverse vaginal septum. Go one step above. Absent vagina and functioning uterus. Just before that, it could be cervical atresia also, congenital cervical atresia. We have published a case. Absent vagina and non-functioning uterus. Uterus is there, but it is not functioning. And then you can think of androgen insensitivity, XY, but female. Constitutional delay. Of course, this is the simplest thing that we can think of, and that's a good thing for the patient. She may menstruate a little later. Rarely resistant ovarian syndrome. It is somewhat like premature ovarian failure, but too premature. Before it could mature, it has become premature. Now, what is opposite of normal? Abnormal, absent, totally absent, secondary sexual characteristics. When the secondary sexual characteristics are absent, it is no-brainer. It means there is no estrogen. If there's no estrogen, we have to blame ovary first, of course, HPO axis in general. Then you look at normal stature. Suppose the normal stature is there, then it could be hyper or hypogonadotrophic hypogonadism. Short stature will be there in pituitary problem, as we know. It could be acquired, which is acting through the hypothalamus, weight loss, excessive exercise, and things like that. If she has short stature, it is obviously pituitary-related hypogonadotrophic hypogonadism. Congenital could be hydrocephalus, acquired could be trauma, and it could be tumors. Okay? Then comes heterosexual, in between. It's neither totally female nor totally absent. It is some feminine but masculine characteristics also, like hirsutism and things like that. We have to think of congenital adrenal hyperplasia, androgen secreting tumors in the adrenals, 5-alpha reductase deficiency, partial androgen receptor deficiency, or hermaphrodite, which is very, very rare, and could be absent Mullerian inhibitor. My last couple of slides is, this is the most important table. Everybody should know this table, even in their deep sleep. And I have split this table into 3 slides so that it is not a crowded slide. First, patient type. Breast absent, uterus present. What does it mean? Breast is absent means no estrogen. Uterus is present means there is no problem with the anomalies of the uterus. So now, lack of breast means lack of estrogen, as I said. And estrogen comes from where? Ovary. HPO failure could be one thing, but mostly it is the Turner's XO, because estrogen doesn't come from pituitary, it comes from ovary. So we have to blame the ovary straight away. Presence of uterus means there is no Y chromosome at all. There's no need to break our head, right? Uterus is present. There's no question of Y being there. How do you distinguish now when you estimate FSH? If estimate of SFH shows it's high FSH, means ovarian failure. O means ovarian failure. But if it is low FSH, we can't always blame the ovary, as you know. because we saw that hypogonadotrophic hypogonadism also can give rise to low production from the ovary. Ovary may be normal, but if pituitary may be abnormal. So you have to estimate FSH. I told you, FSH, FSH, FSH. High FSH means ovary to be blamed. Low FSH means hypothalamus or pituitary to be blamed. Now, how to differentiate between whether hypothalamus is at problem or pituitary is at problem? For that, you have to do what is called GnRH stimulation test. When you give GnRH, what is it supposed to do? It is supposed to encourage production of gonadotropins from the pituitary. In cases of hypothalamus failure, pituitary will beautifully secrete LH on injection of GnRH. Whereas, in spite of giving GnRH from outside, if there is no rise of LH, that means pituitary is to be blamed. I hope this is very clear. Take a screenshot of this. This is very important and very simple. Second case, breast is present. When breast is present, what does it mean? Estrogen is there. We can give clean chit to hypothalamus pituitary ovarian axis. But uterus is absent. When uterus is absent, there are only two conditions. What are the two conditions? One is Mullerian agenesis. That is RKH syndrome. Other one is presence of Y, that is testicular feminization syndrome or androgen insensitivity syndrome. Now, how do you estimate, distinguish further? You can estimate the testosterone. If it is Mullerian absence, then the hormones are in the female level, obviously, right? Because she doesn't have Y chromosome. But if it's a case of testicular feminization syndrome, testosterone will be in the male levels. Further, you can do genetic testing or chromosomal karyotyping to find out that also. And the last case is breast is also absent, uterus is also absent. This is an extremely unfortunate, very, very rare situation where lack of breast means lack of estrogen. There is gonadal dysgenesis maybe, or agenesis maybe, or even hypothalamus pituitary problem maybe. And unfortunately, she also doesn't have uterus. There will be presence of Y chromosome could be there. To solve this case, you have to do karyotyping. If it is 46XY, it is very clear. Serum testosterone also will be in the female range. Okay. Now, management. Very, very easy. Having understood all these things, I can finish in 3 slides. Number 1, how to deal with hypergonadotrophic cases. You have to do chromosome study to reconfirm that it's a case of Turner syndrome. If by chance you find XY, okay, you have to do gonadectomy. Why? This case can go for cancerous of the gonads. What's the option for her? She's a case of XY. So the option for her is that you have to do gonadectomy and then vaginoplasty. You can give estrogen progesterone supplementation to her just to look feminine, but she cannot have children. You have to go for adoption. If it is XO, which we know as Turner's, so here there is deficiency of estrogen. We have to maintain the femininity, give her cyclical estrogen progesterone. That will also give rise to some menstruation artificial to promote feminization and prevent osteoporosis. That is more important rather than having menstruation, prevention of osteoporosis. Oocyte donation is the only way to have fertility in such cases. If it is XX, right? So it could be a Savage syndrome, or it could be like pure gonadal dysgenesis or Swyer syndrome. There is ovarian resistance. That's all we can understand clearly. And there is receptor problem in Savage syndrome and FSH problem in the other thing. It would be whatever it is, like a same as XO. You give cyclical estrogen progesterone to promote feminization and prevent osteoporosis, and oocyte donation later in life for fertility. What to do in cases of eugonadotrophic? You again do chromosomal study. Suppose it turns out to be XY, because in eugonadotrophic, we usually think that HPA axis is already, there is something wrong with the uterus. So if it is a case of testicular feminization syndrome, and XY will be the chromosomal study. If it is XS, then you have to probably think of a case of RKH syndrome. Again, if it is XY, you have to do gonadectomy, vaginoplasty, looks like the previous slide. And then if it is XX, that is arcade syndrome, there, of course, there's nothing you can do except probably Professor Puntambekar can do a utriculoplasty, but otherwise we have to just create a vagina for functional things or sexual activity, and surrogacy is the best answer. With cryptomenorrhea, this is probably the simplest case to solve. Hymenectomy is all that you need, cruciate incision, and vaginoplasty is other thing that you can do if there's a vaginal septum. If it's a case of PCOS giving rise to primary amenorrhea, which is very, very rare, I have written, usually I like it as refer to my PCOS class, it's another class by itself. If there is hirsutism, mechanical removal of hair plus anti-androgens can be given. Finally, we come to hypogonadotrophic and other causes. Hypogonadotrophic means problem with the hypothalamus or pituitary. So you have to think of giving FSH, HMG therapy. HMG is better because it gives both FSH and LH. If it is a case of hypothyroidism, thyroxine is the answer. If it is a case of pituitary tumor, surgical removal is the answer. Hypothalamic and pituitary dysfunctions, of course, you have to treat accordingly. For femininity, you give cyclical estrogen, progesterone. And for fertility, you give ovulation induction. If it is due to nutritional cause, then the answer is nutritional manipulation, a high-sounding word, whatever it means to you, or refer to a nutritionologist. That's where I stop. I hope you have understood clearly. It's very, very simple.
Excellent, Dr. Muralidhar.
Thank you, ma'am.
Absolutely exhaustive, but crystal clear. I think it was a good revision of everybody, including me also. And amenorrhea is so tough topic, and you made so interesting that all the fellows must have been benefited by this. Thank you so much.
Thank you so much, ma'am. Thank you so much. Coming from you, it means a lot.
Thank you, sir. It was very nice and elaborate, and everybody understood it very clearly, even us.
Very, very
I really appreciated your lecture, Anaga.
Kasturi madam, would you like to say something? Excellent, sir. We are like speechless, and the way you have simplified it is something to learn from you, because all those charts, our students also get lost, and we also get lost in all those charts, flow charts, what we have. But one by one, and the clinical tips which we gave, which you gave, was like wonderful. They will stay with everybody forever, and you really made our day today. Thank you so much for an excellent presentation.
Ma'am, we have
Thank you,
Kasturi
ma'am.
ma'am who's
Chat
joining
box.
us.
There is
Thank
no
you so much,
question.
sir.
Yes,
Hello.
Madhu?
Yes.
Yeah.
Kasturi.
Kasturi ma'am is there.
Yeah,
Madam, can
yeah.
you unmute?
Madam is there. I called madam's name. I can see madam. Madam, if you can unmute and please give your chairperson's remarks. Anaga, you really gave a great overview, and then Sir built on that, really simplified it.
No,
So
sir
like
simplified
went
it so well, so
Yes.
well. It
Ma'am,
was like
overview
for us
into
also it
clinical
was.
view.
Yes.
Ma'am, overview converted to the clinical picture, clinical
Yes.
practice.
True, true.
Yes,
Very
yes.
well, very well.
Dr.
Excellent.
Padma Rao, my professor,
Really
used to always
excellent
say
talk,
we have
sir.
to keep repeating to reinforce. So that's what happened. Anaga said, I also repeated the same thing, but I think that's the only way.
Yes, yes, yes. True.
Beautiful.
Kasturi madam, can you unmute and can you
Fine, sir.
please...
Excellent talk.
Thank you, Kasturi. Thank you so much for inviting me. Yeah.
Thank you, sir. Thank you so much. Thank you, Anaga. Thank you, Muralidhar, sir. Thank you so much. And now I request Madhu to please take the session forward.
Thank you, ma'am. Thank you so much. I would again like to thank both of the
My
speakers
problem,
for
there was
being.
some problem with my mobile, this thing, I don't know. It was not getting unmuted. Am I audible now?
Yes, yes, you
Yes,
are
ma'am.
audible, madam.
So excellent talk, sir, by sir, and as always, we hear all his lectures, excellent. And he made the most difficult topic most easiest, simplest way. So I think every student all over India should listen to this, and they will feel very confident, and we wish that they will get a case of primary amenorrhea or amenorrhea for the exams after hearing your talk, sir. So excellent.
I'm sure this talk will be on the YouTube. On my channel also, this primary amenorrhea and secondary amenorrhea talks are there, and they have got the maximum views actually to say.
Yes.
Yeah. Okay.
Yes.
Thank you.
Really, it was too good.
Yeah,
And
thank
Anaga,
you.
your talk was also very basic and very nice. You made it so simplified. Thank you.
Excuse me,
Thank you.
I will I'll leave this now because I have some other meeting
Yes.
to attend.
Yes.
Okay.
So
Thank you,
thanks
sir.
a ton for your time, sir. Thank you, sir. So much appreciated series of talk today on primary amenorrhea. We continue it for the PGs by conducting a question and answer by our special friend, Dr. Mansi. Mansi, over to you. Let's have it. Let's make it more interesting by your question and answers, which are on Kahoot.
Thank you so much, Madhu. So we will be starting with the quiz on amenorrhea. First, I would like to thank the speakers for such a detailed and simplified topic on such tough topic that it was a pleasure to listen to the talks today. May I request Trusha to share the QR code for the time being? This is the QR code which is visible on your screen for the quiz today. We will also be sharing the link on the screen or on the chat box. You can join through the link as well. I will request everyone to please write your name and join. We have 5 rounds for the quiz. As usual, the first round is the Pehchan Kaun or visual round, where we try to take as many scientists or known discoverers which are famous for their discovery related to the topic which we are taking today. Trisha, are you there?
Yes, ma'am.
Okay. We will be waiting for 5 more minutes so that a number more people can join us for the quiz.
Okay, ma'am.
Yeah. We have 5 rounds. Each rounds have 5 questions, and the questions are related to the topic we have taken today. And I'm sure after such a simplified and detailed discussion, and we will be able to answer some questions. It was really very nice talk. We learned a lot today. If anybody has any difficulty in joining the quiz, please let us know. You can join through this QR code. Risha, can you please share the link also in the chat box, please?
Yes, ma'am.
If anybody is having difficulty in joining through the QR code, we will be sharing the link also. You can directly join through the link as well. Trisha, can you please share the link? I think a lot of people are not able
Yes,
to.
yes, ma'am. I have sent in a chat box.
The link is in the chat box. Please let me know if you're not able to join through the link as well. I think should we start with the quiz?
Okay, ma'am, should I move to the first round?
Yeah, just give me. Trisha, is it possible for us to keep the QR code on the side?
Yes, ma'am, it's possible.
Yeah, just keep the QR code on the side and we'll start with the first round.
Okay, ma'am.
We will be starting with the first round, and the round is Pehchan Kaun. This is a visual round where we will be showing you pictures, most of them as the famous personalities. Can I have the first question of this round, please? You have to identify this famous personality. And from the options, you can see this is related to one syndrome. The options are August Franz Karl Mayer. The second option is Karl von Rokitansky. The third is Hermann Kuster. And the fourth is George Hauser. So who is this gentleman? A very famous personality related to the syndrome. Yeah, so time's up. Okay, 5 of you are correct. Yes, he is Karl von Rokitansky, also known as Rokitansky syndrome. He was an Austrian physicist as well as the pathologist, physician and pathologist. He discovered anatomical abnormalities related to absent uterus and vagina while conducting autopsies in females. Can I have the next question, please? You have to identify this syndrome, a much easier question, whether it is Swyer syndrome, Savage syndrome, androgen insensitivity syndrome, or Turner syndrome. The picture is very clear. The time is almost up. Yes, 4 of you are correct. The correct answer is Turner syndrome, very easily identifiable. Short stature, webbed neck, broad chest, widely spaced nipple. Can I have the next question, please? You have to identify again a famous personality. The options are there, whether he's Henry Turner, George Hauser, Sir Archibald McIndoe, or Otto Ulrich. Like I told you, for this round, we have kept a lot of famous personalities related to the syndromes we are talking in association with primary amenorrhea. I have given you a very big hint. So let's see who's got it. Okay, 4 of you are correct. He is Henry Turner, an American physician who was, while studying a group of 7 girls who were having abnormal physical characteristic, identified and discovered the Turner syndrome. Can we have the next question, please? Okay, what is the most likely diagnosis? This is a USG picture. Whether it is an ovarian cyst, whether it is a hematocolpus, whether it is ectopic kidney, or whether it is an hematometra. If you look very closely, you can see a bladder identification there, uterus there. What is the most likely diagnosis here? Yes, 5 of you are correct. That's a hematocolpus. Can I have the next question, please? Again, identify this famous personality. The options are August Karl Mayer, Franz Joseph Kalman, Hermann Kuster, or Robert Reber. Normally, we do not have so many identification related to the personalities or scientists, but a lot of syndromes related to primary amenorrhea. Yes, 7 of you are correct. It is Franz Joseph Kalman. He was a psychiatrist of German descent, and he identified a syndrome related to primary amenorrhea, color blindness, and anosmia, known as Kalman syndrome. So what is this? Can I have the scoreboard after this round, please? We have Sonalika leading, followed by Yukti, Shweta M, and Priya. We move on to the second round after this. The first question for this round is, what is the most common cause of primary amenorrhea? Whether it is Kallmann syndrome, whether it is gonadal dysgenesis, whether it is Mullerian agenesis, or whether it is anorexia nervosa. Sir just said this answer right now while during his presentation. Five of you are correct. The correct answer is gonadal dysgenesis. It's the most common cause of primary amenorrhea. We move on to the next question. What is the most common mode of transmission for complete androgen insensitivity syndrome? Whether it is X-linked, whether it is sporadic, whether it is autosomal recessive, or whether it is autosomal dominant. You have to identify 4 seconds remaining. Yes, 4 of you are correct. It is a X-linked recessive disorder, rare disorder related to androgen receptor mutation. Can I have the next question, please? A 15-year-old girl with primary amenorrhea has low FSH and LH. She has anosmia and normal MRI pituitary. Which gene mutation is the most likely? Whether it is CAL1, whether it is SHOX, whether it is SRY, or whether it is CYP11B1. Most of the questions are, you have to identify the diagnosis and the question is related to that diagnosis. So what is the correct gene mutation? Yes, 8 of you are correct. It is CAL1 gene mutation causing Kallmann syndrome. It is hypogonadotropic hypogonadism, low FSH LH, anosmia, and normal MRI pituitary. Can I have the next question, please? A 16-year-old girl with primary amenorrhea, normal secondary sexual characteristics, cyclic pelvic pain, and bulging bluish membrane at the introitus. Which embryological structure failed to canalize? Whether it was Mullerian duct, whether it was urogenital sinus, paramesonephric duct, or cloacal membrane. So what is the diagnosis and which embryological structure failed to canalize to cause that diagnosis? Yes, 6 of you are correct. The correct answer is urogenital sinus. The diagnosis was imperforate highness, and the correct answer is urogenital sinus. Can I have the next question, please? A 16-year-old girl presents with primary amenorrhea, height 182, BMI 20, Tanner stage 3 breasts, scant axillary hair, and no uterus on USG. Serum testosterone 700, adult male. FSH is normal. Karyotype is 46XY. Which gene is likely mutated? CYP21A2, AR gene, CYP17A1, or FMR1. So which gene mutation is likely? 3 of you are correct. The correct diagnosis is androgen insensitivity syndrome. The gene mutation is androgen receptor gene on XQ1112 chromosome. So the B is the correct answer. If you can see correctly, primary amenorrhea, FSH normal, karyotype is 46XY, and serum testosterone in the normal adult male level. Can I have the next question? I think we have the leaderboard now. The leaderboard, there's slight change with Yukti taking the first position, followed by Sonalika, Dr. Shokin Sheikh, and Shweta M. Can we have the third round now? Which of the following is the earliest investigation to differentiate between gonadal dysgenesis and hypothalamic amenorrhea, whether it is pelvic USG, whether it is serum FSH, whether it is serum estradiol, or whether it is MRI pituitary? I think it will be a much easier answer. Yes, 9 of you are correct. We just discussed serum FSH is the right answer. Can we have the next question, please? In differentiation between MRKH syndrome and complete androgen insensitivity syndrome, which single investigation is most helpful? Pelvic USG, serum testosterone, laparoscopy, and karyotyping. I think we may have some confusion regarding this answer. Let's see. Yes, 6 of you are correct. Karyotyping will give the correct answer. Complete androgen insensitivity, XY, absolutely confirmed answer. Can we have the next question, please? Which enzyme deficiency causes primary amenorrhea, sexual infantilism, hypertension, hypokalemia, 21-hydroxylase, 17-alpha-hydroxylase, 11-beta-hydroxylase, or aromatase? These are deficiency. Which enzyme deficiency of these causes all these symptoms? Six of you are correct. The correct answer is 17-alpha-hydroxylase deficiency. Can we have the next question, please? In primary amenorrhea with absent uterus, all are possible diagnoses except Mayer-Rokitansky-Kuster-Hauser syndrome, complete androgen insensitivity syndrome, Sayers syndrome, or 17-alpha-hydroxylase deficiency. We just covered this in the discussion. As only one of you are correct. Sawyer syndrome, everything is present. They are almost female, so they do have the uterus. I think again slightly confusing between the 17-hydroxylase and that. That's why a lot of confusion was there. A 14-year-old complained of absence of menses, growth spurt at 11 years, normal breast pubic hair development which began 3 years back, appropriate height, no medical history and no history of cyclical abdominal pain or sexual contact. Per abdomen and local examination was normal. Per rectal uterus was felt. What is the next step? Hormonal profile, hormone replacement, pelvic USG, or observation? Okay. See, the correct answer is the last. Here, whichever one has given pelvic USG can be correct, but here because we have felt the uterus in per rectal examination, she's only 14-year-old with a sexual history development which was present 3 years, since 3 years. So the secondary sexual characters are developed. She's only 14. We can still give her time to see whether she's spontaneously menstruating herself or not. So right now we can still wait and see, wait and watch. So the correct answer is the last, which is D. A lot of questions are going to be there which will feel like this is the correct answer or that are there. They are specifically kept to make it more confusing. The scoreboard is the same, but Dr. Mansi, I would appreciate her. She has the longest streak of 11 correct answers. So very good, Dr. Mansi. Can we have the next round, please? We move on to the round 4. Patient has primary amenorrhea, high FSH, normal karyotype, autoimmune thyroid disease. What is the most likely diagnosis? Whether it is Turner syndrome, whether it is autoimmune premature ovarian failure, whether it is Kalman syndrome, or whether it is Sayre syndrome. Patient has normal karyotype, high FSH, and autoimmune thyroid disease. Yes, 8 of you are correct. It is autoimmune premature ovarian failure. Can we have the next question, please? "17-year-old with primary amenorrhea, high FSH, LH, streak gonads, tall stature, 46XY karyotype. Which tumor risk is highest if the gonads are not removed? Sertoli Leydig cell tumor, granulosa cell tumor, gonadoblastoma, or Brenner tumor?" Yes, 6 of you are correct. The correct answer is gonadoblastoma. Can we have the next question, please? Which of the following is not a cause of primary amenorrhea with normal secondary sexual characteristic, whether it is MRKH syndrome, transverse vaginal septum, imperforate hymen, or Turner syndrome? Correct answer is Turner syndrome. 8 of you are correct. Can we have the next question, please? "15-year-old girl with primary amenorrhea, absent breast development, normal pubic hair, small uterus on USG, FSH is high, LH high, low estradiol, karyotype is 46XX. What is the most likely diagnosis? Turner syndrome, pure gonadal dysgenesis, hypothalamic amenorrhea, or Kalman syndrome?" Six of you are correct. Pure gonadal dysgenesis is the correct answer with normal 46XX karyotype and hypergonadotropic hypergonadism. Can I have the next question, please? "16-year-old with primary amenorrhea has short stature, webbed neck, shield chest, widely spaced nipple. Which cardiovascular anomaly is the most commonly associated? Whether it is tetralogy of Fallot, coarctation of aorta, patent ductus arteriosus, or transposition of the great arteries?" Yes, correct answer is coarctation of the aorta, most common cardiovascular anomaly. Can we have this leaderboard after this round? Okay, we are moving on directly to the round 5. This is the last round. In primary amenorrhea, due to 17-hydroxylase deficiency, which of the following finding is most expected? Whether it is high cortisol, high androgen, low BP, low cortisol, high androgen, high BP, low cortisol, low androgen or high BP, or high cortisol, low androgen and low BP. Okay. The correct answer is C, 17 alpha hydroxylase deficiency leads to low cortisol, leading to low androgens and high mineralocorticosteroid, high BP. So high androgens are not there, it is low androgen. So the correct answer is C. Can I have the next question, please? 15-year-old gymnast, BMI 16, primary amenorrhea, breast tanner stage 2, low FSH, LH and estradiol, normal MRI, normal sense of smell. Which feature will suggest functional hypothalamic amenorrhea over constitutional delay? Normal bone age, family history of delayed menarche, high IGF-1 levels, or presence of anosmia. You have to differentiate between constitutional delay and functional hypothalamic amenorrhea. Okay. See, when we see, though family history is very important in cases of constitutional delay, but the bone age is the most important factor. Functional hypothalamic amenorrhea has the normal age, corresponding age, whereas in case of constitutional delay, there will be a difference. So the correct answer is normal bone age for chronological age. Can I have the next question, please? Which dynamic test can be used to differentiate hypothalamic from pituitary causes of hypogonadotropic hypogonadism in primary amenorrhea? TRH stimulation test, GnRH stimulation test, ACTH stimulation test, or water deprivation test? Sir has taken this in his presentation as well. Yes, GnRH stimulation test is the correct answer. Can we have the next question, please? Women with 45X, 46XY mosaicism with streak gonads present with primary amenorrhea, USG, small uterus. What is the next best step? Whether you will start estrogen therapy, delay treatment up till 18 years, prophylactic gonadectomy, or only follow up and monitor? What will be the next best step? Okay, I think if you would have seen the slide which sir has shown, the first line which he had written was gonadectomy followed by estrogen progesterone. So the right step would be first you do the gonadectomy because the chances of malignancy are more. Correct, you have to start the estrogen progesterone, but you first do a gonadectomy and then start the estrogen progesterone. So the correct answer is C, prophylactic gonadectomy. Can I have the next question, please? Okay, you have to identify this personality. It is a very recent like development or discover not very recent thing which whether he's Dr. Andres Desax, I do not want to give more because you will understand. Henry Turner, Sir Archibald McKinley, or Max Brandstorm. So, okay, two of you are correct. He is Professor Max Brandstorm. He just performed in 2012 the first uterine transplant. Till now, more than 100 uterine transplants have been done for MRKH syndrome. So I had just kept it like that to know the recent development related to primary amenorrhea. Can I have the leaderboard, please? Okay, so we have the scoreboard with Yukti leading, followed by Sonalika, Dr. Shokin Sheikh, Jacqueline, and Dr. Mansi having 13 longest streak record of correct answers. So please, big round of applause for all the winners and very nicely done. It was a very difficult topic, but really nicely done. And I had made it a lot of confusing because a number of questions I've mixed in and made it one question. So very nicely done. Congratulations.
Thank you, Dr. Mansi. I hope the PGs enjoyed this discussion and the quiz, which is made simplified by Dr. Mansi, as well as interesting to attempt to. And congratulations to the winner. We are ending this episode 4 of the Harmony series, where I think there's much of taking back home. And I would request Dr. Vaishali Korodinayak, Madam, to give the vote of thanks to all the speakers.
Yes, thank you, Madhu. I'm driving, so my camera is off. Thank you, Mansi, for an excellent quiz. And today, really, we had a great academic session. We thank all the speakers, both of them, Dr. Anagha and Dr. Murlidhar, sir, and our chairpersons, Dr. Sudha, madam, and Dr. Kasturi, madam. Thank you so much for an excellent session. Madhu, you managed it so very well. Mansi, excellent quiz. And I would like to thank FOGSI President, Dr. Sunita Madam, as well as ICOG Chairperson, Dr. Parag Sir, and our own Dr. Chaitanya Ganpule, who is sitting chairperson of FOGSI Endocrinology Committee, for having this excellent session. And it was our 4th of such. And we are looking forward to cover the whole of the endocrinology in the same sequence. So stay with us. We will meet you on 3rd Wednesday of next month again. So see you and take care by then. Thank you.
Thank you, ma'am. Thank you, everyone, and good day. Thank you, Mansi. Bye-bye.